Hello, everyone. Yesterday, we were running out of time when I was explaining the prophylaxis of febrile neutropenia. I'm concerned that in that rush, I didn't explain it as well as I could have, and in addition, I was sensing some confusion. So I thought I would record a quick supplement to the lecture to help you learn this topic. In addition, I created a quick reference document a few years ago for a CE event for pharmacists about febrile neutropenia, and I've posted that quick reference document on eClass because I thought it might be useful to you as well. So for prevention, granulocyte colony-stimulating factors such as filgrastim or pegfilgrastim can be used to reduce the risk of febrile neutropenia. They have been shown to reduce infections and all-cause mortality and prevent dose reductions of chemotherapy. However, there are some drawbacks. These drugs are very costly, and insurance coverage can be an issue. They can have some side effects, and given that they are administered subcutaneously, sometimes administration can be an issue. When we think about prophylaxis, there are two categories. Primary prophylaxis refers to the use of colony-stimulating factors for prevention of febrile neutropenia, starting with the very first cycle of treatment and continuing through all subsequent cycles. Primary prophylaxis is generally recommended for patients that are at a 20% or higher risk of developing febrile neutropenia. So, how do we know whether a person is at a high risk of 20% or greater for FN? Well, we need to consider patient factors such as their age. Typically, older patients can be at higher risk. Disease factors, and also the chemo drugs themselves and what their reported incidence of febrile neutropenia is. Decisions regarding which patients will be prescribed primary prophylaxis is typically made at the institution level based on evidence. So, for example, at the Tom Baker, all patients who are over the age of 60 years old that are getting R-CHOP for diffuse large B-cell lymphoma will receive primary prophylaxis. However, patients under the age of 60 would not get this prescription up front. And this is based on the evidence that patients that are over the age of 60 with diffuse large B-cell receiving R-CHOP have benefit from filgrastim because their risk of FFN is higher. It is also important to note that this really only applies to patients where a treatment goal is cure or substantial extension of life. A person whose goal was palliation or improvement of quality of life would not be given a chemotherapy regimen with such a high rate of myelosuppressive side effects or toxicities. So what if a patient wasn't a candidate for primary prophylaxis and they end up with FN, like our patient TY yesterday? For these patients, we can consider secondary prophylaxis or giving a colony-stimulating factor with all subsequent cycles of chemotherapy. In some cases, we could consider a dose reduction or perhaps a dose delay of their chemotherapy. But if there is a risk of a patient not meeting a really important treatment outcome, such as cure, by modifying the dose or the schedule, we need to give them secondary prophylaxis. Hence, secondary prophylaxis is not really seen in the palliative setting. We don't need to maintain the dose intensity or the dose density for this population because our goal is just improving quality of life. But when our patient's goal is cure, we need to keep them on track with their chemotherapy. Granulocyte colony-stimulating factors are administered subcutaneously. For ambulatory patients, an administration plan needs to be developed. Some patients are comfortable administering it themselves or have a care provider that can administer it for them. Some patients may require home care. A less common plan, but one that I see becoming more and more popular in the future, is engaging with community pharmacists for administration. For your reference, I have provided the general dosing information for filgrastim and pegfilgrastim. Filgrastim is given once daily for a few days between each cycle. The start date and the duration are dependent on the chemotherapy protocol and somewhat on physician preference. Recently, the Common Drug Review granted approval to a subsequent entry biologic or biosimilar type of filgrastim. Its brand name is known as Grastafil. After this approval, many provincial drug plans changed their benefit lists. Here in Alberta, Blue Cross no longer covers Neupogen, which is the brand name original product. Instead, it's now the Grastafil brand that is covered for appropriate patients based on a special authorization and approval. Pegfilgrastim, because it's pegylated, can be given as a single dose once daily. It's usually given 1 to 3 days after they've received their chemotherapy. Neulasta is still covered by Alberta Blue Cross, but again only under special authorization. With all colony-stimulating factors, patients can experience bone pain as a side effect. Oftentimes, patients will talk about this achy bones that they get a few days after they get their filgrastim. This can typically be managed with acetaminophen, and we don't really need to worry as much about monitoring for temperature or masking of fever because they've received medications that will prevent them from becoming neutropenic. For some patients, FN prophylaxis may be given by prescribing a quinolone antibiotic. This is an option for patients with high risks of prolonged or profound neutropenia. It is likely to reduce the risk of infection. However, there are some risks involved with this, such as developing something like C. diff colitis, or maybe an infection with a quinolone-resistant organism, such as a quinolone-resistant E. coli. Thanks very much, you guys, and I hope that this is helpful for you, and I will see you tomorrow. Thanks.